Hello, everyone. My name is Dr. Edward Lee from Boston Children's Hospital and Harvard Medical School. Today, we're going to discuss essentials of chest imaging, focusing on pediatric COVID-19. My co-speaker is Dr. Alexandra Foust from Boston Children's Hospital and Harvard Medical School.
Thank you, Dr. Lee. Today we're going to be discussing three main learning objectives for COVID-19. First, we're going to talk about imaging findings in COVID-19 pneumonia in pediatric patients. Then we're going to discuss the suggested structured reporting categories that can be used in these patients. And finally, we'll review imaging recommendations for pediatric patients with known or suspected COVID-19. So we'll start off with talking about what is COVID-19. The coronavirus disease of 2019 is caused by the severe acute respiratory syndrome coronavirus 2, which has also been called SARS-CoV-2. This virus is a single-stranded positive sense RNA virus, and it's named for the similarity of the appearance of its spike-like surface proteins to a crown. The transmission is believed to have been zoonotic in origin, with bats favored as the natural reservoir, and the virons are spread through inhalation as the main mode, although there have been cases reported of spread through conjunctival membranes. The virus, once inside the body, binds to ACE2 receptors in the alveolar epithelial cells and triggers increasing levels of ACE2, which subsequently lead to alveolar damage. Elevated pro-inflammatory cytokines and chemokines have also been observed in these patients and are felt to play a role in the process of pathogenesis. There are a few challenges that need to be considered when looking at what we know about pediatric COVID-19 so far. First, there have only been a small number of reported pediatric cases in the literature, and the imaging studies across the literature have been performed often with non-standardized technique across multiple different countries. Second, since we don't have that many cases, there is not any good radiology-pathology correlation so far. And third, we don't have any short-term or long-term follow-up in pediatric patients to work off of. Despite these limitations, we've created our recommendations based on existing literature, what we do know, and also based on some world expert experience with prior coronavirus diseases, including SARS and MERS. There are a few special imaging considerations that need to be taken into account for any imaging study in pediatric patients. Off to the side there, for some real-world value, I have a picture of my son and I together in the living room. Okay, so talking about pediatric patients, first off, they have immature lung anatomy and their immune systems are still developing. This means that they may have different clinical and radiographic appearances compared to what we see in adult patients. Second, pediatric patients often have a decreased ability to communicate symptoms, especially in those who are too young to talk or who have developmental delays. Finally, pediatric patients have an increased radiation sensitivity compared with adults, and so this needs to be taken into consideration when making decisions about imaging exams. Chest radiographs in pediatric patients with COVID-19 may be normal. However, there are some findings which can be helpful if present. The most classic findings reported across the literature so far are consolidative and ground glass opacities in a bilateral distribution in the mid and lower lung zones with a peripheral distribution. And to the right, we have an example of a typical patient who has ground glass opacities in the right lower lobe and a more consolidative opacity in the left lower lobe, both of which are somewhat peripheral in distribution. However, as with many things, CT often shows a greater extent of disease than chest radiographs, or may show these in patients who have negative chest radiographs. In our paper, we created 4 categories for structured reporting of chest radiographs in pediatric patients with suspected COVID-19 to help improve confidence for practicing radiologists. The typical category is used to describe the most classic findings observed in pediatric COVID-19, namely the bilateral, peripheral, ground glass, and consolidative opacities. And so we recommend that for this category, you should at least bring COVID into the conversation and say, COVID-19 pneumonia can commonly present with these types of imaging findings. However, there are still some differential diagnoses, such as viral or atypical pneumonias, that could be considered. The indeterminate category is used for pediatric patients who have imaging findings that can be seen in COVID-19, but also have a much broader differential. So this includes things like unilateral, peripheral, or peripheral and central ground glass opacities, because bilateral is the more classic pattern. the presence of bilateral peribronchial thickening or peribronchial opacities, as can be seen with reactive airways disease or other viral illnesses, and the presence of multifocal or diffuse ground glass opacities that don't have any specific distribution. For this category, we tried to use a little bit less firm language, stating that these findings can be seen in COVID-19, however, they're nonspecific and the differential diagnosis is broad. The atypical category is where the radiologist can add, I think, more value. This category is where we would report findings that are atypical for COVID-19, and we should recommend to our referring providers that they may need to consider alternative diagnoses. This includes findings like a unilateral segmental or lobar consolidation, as would be more expected to be found with a bacterial pneumonia. This includes central, unilateral, or bilateral ground glass opacities, because the central distribution is atypical for COVID-19 by itself without any sort of peripheral distribution. It includes the presence of pleural effusion or lymphadenopathy, which are very rarely reported in COVID-19 patients. And it includes a single round consolidation that has well-defined margins, such as we would expect to see in a round pneumonia. So this is really where I think the radiologist can add a lot of value to referring providers. Finally, the negative category is what you would use when there's no chest radiograph findings to suggest. Next, we're going to go over a couple of examples of the categories that we described on the previous slide that can be used in identifying COVID-19. To the left, we see a typical chest X-ray that would raise concern for COVID-19 pneumonia. It has bilateral, lower predominant, and peripheral predominant ground glass and consolidative opacities. In the middle, we see an example of what we would put into the indeterminate category. We have a central ground glass and consolidative opacity on the left, and a more ground glass opacity in the right apex adjacent to a pneumothorax. This was a patient who had COVID-19, but this is not the classic presentation and so goes into the indeterminate category. Finally, on the right, we have an example of an atypical presentation, and this is a well-defined opacity in the right upper lobe and has imaging appearance more suggestive of something like a round pneumonia than COVID-19. This is an additional case of the typical appearance of COVID-19 pneumonia. This is a 21-year-old male who presented to our institution with dyspnea. He had a history of sickle cell disease and was found on admission to be positive for COVID-19. On chest X-ray, you see the classic distribution of lower lobe predominant ground glass opacities that tend to be more peripheral in their distribution. Next, we're going to talk about the chest CT findings for pediatric COVID-19. As one might expect, based on what we talked about in the radiograph section, the distribution is the same. We see bilateral ground glass and consolidative opacities, which tend to have a peripheral and lower predominance. One thing on CT we can see better is the more subpleural lesions. Another thing that can be seen on CT in pediatric patients is the presence of the halo sign, which is seen in early cases and hasn't been described in the adult literature. Other findings in pediatric patients that you might see include bronchial wall thickening and peribronchovascular opacities, which have been described more frequently in pediatric cases of COVID-19 compared to adults. Crazy paving pattern of intralobular septal thickening can also be observed, but has been reported with a lot less frequency across the literature in pediatric patients compared to adults. Finally, as we mentioned before, lymphadenopathy and pleural effusion are very rare in pediatric patients, and if you see these findings, you need to open your differential. In our example provided on the slide, we have a 21-month-old female who had Hurler's disease and had a prior bone marrow transplant who presented with fever and respiratory distress. On the image, you see the peripheral distribution of ground glass opacities in the bilateral lungs, which is very classic for the typical appearance of COVID-19. And unfortunately, this patient subsequently succumbed to disease.
As more pediatric COVID-19 cases have come to attention, we've begun to see some evolution of imaging findings on chest CT. In the early phase of infection, the halo sign may be observed, which corresponds to a rounded area of consolidation with a surrounding rim of ground glass opacity. Hence, local inflammation in the lung with surrounding vascular congestion. As the infection begins to spread to adjacent alveoli and a pattern of alveolitis, the imaging appearance changes to more diffuse ground glass opacities. Finally, as the alveoli become filled with fluid and inflammatory cells, a more developed and consolidative appearance is visualized on chest CT. The figure on the slide demonstrates these findings. Figure A, in a 14-year-old patient, shows an early halo sign with a subtle rim of ground glass. In figure B, there are still some small consolidations, but there's more diffuse ground glass opacity in the surrounding lung parenchyma. Finally, in figure C, you can see a more consolidated, evolved state of infection.
Similar to what we described in chest radiographs, we also created 4 categories that can be used to describe CT findings in pediatric COVID-19 patients to help radiologists improve comfort and accuracy in diagnosing COVID-19. The typical category, similar to with chest radiographs, has the distribution that we expect to see of bilateral peripheral and subpleural ground glass opacities or consolidation in a lower lobe predominant pattern. Additionally, the halo sign, which is the central area of consolidation with the surrounding rim of ground glass, has been included in this category as it is a sign often observed in early cases of COVID-19. For this category, we again report that these imaging findings are commonly seen in COVID-19 patients. However, the differential diagnosis does include viral and atypical pneumonias, hypersensitivity pneumonitis, eosinophilic lung disease, and in cases of immunocompromised children, if you see the halo sign, you also need to raise concern for possible fungal infection, such as an angioinvasive aspergillosis. The indeterminate category is again used for findings that can be seen in COVID-19, however, are not classic or typically seen. Again, you'll see the unilateral peripheral and central ground glass or consolidative opacities, which, as we previously discussed, is included here because it doesn't have the bilateral pattern that we expect to see. Other findings in this category are bilateral peribronchial thickening or peribronchial opacities, as might be seen with common viral respiratory illnesses or reactive airway disease. We also put crazy paving into this category as it's not seen as frequently in pediatric patients with COVID-19. And finally, just random distribution of ground glass and consolidative opacities that doesn't confine to the periphery or lower lobes. This category, again, we say these are features that can be seen in COVID-19, but they're not specific, and the differential is, again, more broad. As with the chest radiographs, the atypical category is where the radiologist can add value the most. And this is the category where you're going to suggest that other diagnoses be considered. Similar to with chest radiographs, findings that suggest alternative diagnoses, such as a unilateral segmental or lobar consolidation, which would suggest a bacterial pneumonia, a central predominant pattern of distribution, which is atypical for COVID. The presence of central lobular or tree and bud nodules goes into this category, as this is something that we would see with more infectious etiologies that are non-viral in nature and have not really been reported in pediatric COVID-19. Additionally, findings such as lung cavitation, pleural effusion, and lymphadenopathy are very rare in pediatric COVID-19, and so should be put into the atypical category and have the reader increase their differential to include other etiologies. Finally, the negative category is again going to be used to report cases where there are no CT findings suggestive of pneumonia. Now we'll talk about a few examples of images that can be put into the aforementioned categories. On the left, you'll see a coronal CT image in a COVID-19 patient who has peripheral and subpleural ground glass and consolidative opacities throughout the bilateral lungs. While there are opacities in the upper lobes, the predominant portion of the infection is in the lower and mid-lung zones, which goes with the typical category. In the middle, we have an axial CT image, which shows what we would consider indeterminate case. We have a ground glass opacity, but it's only unilateral in the lower lobe. It has a bit of consolidation mixed in with it. So the distribution and the location are good, but the fact that it's unilateral means that we have to put it into the indeterminate category. This patient did end up to have a COVID-19 infection. On the right, we have 3 examples of what would fall into the atypical category. The top image shows a central predominant consolidative and ground glass opacities, and this is a confirmed case of varicella pneumonia. In the middle, we have tree and bud and centrolobular nodular opacities in the middle lobe and lingula, and this was a mycobacterial infection. In the bottom, we have a cavitary lesion in the right lower lobe, and this was a Staph aureus abscess. Next, we're going to talk about an additional typical case, and this is a case from our institution, which is nice because we have a typical appearance both radiographically on the chest x-ray and on chest CT. And this was a 15-year-old patient who didn't have any substantial past medical history, but did have a mother who had known COVID-19 pneumonia and presented to us with cough and fever. The chest radiograph shows lower lobe and somewhat peripheral predominant ground glass opacities, which would fit into the typical category. But as you can see, the CT shows a much greater extent of disease, as we previously discussed. Again, we see the peripheral and subpleural distribution and mixed ground glass and consolidative opacities, which is typical for COVID-19 infection. In the second portion of our paper, we focused on providing some imaging study recommendations to be used for workup of pediatric patients with known or suspected COVID-19 infection. Decision to pursue imaging evaluation in these patients should be made after taking time to consider the potential risks and benefits. Potential risks include a non-diagnostic exam, the risk of radiation exposure in pediatric patients, as well as risk to radiology staff from exposure to a patient with known COVID-19, and increased turnaround time for radiology rooms and equipment. Potential benefits include informed decision-making when you're trying to decide about triaging a patient and isolation measures that may need to be made. You have established baseline imaging for the patient, and you've had the opportunity to identify alternative differential diagnoses or comorbid conditions that could be contributing to the patient's symptoms. For any pediatric patient, the exposure history and the presence of comorbid conditions play an important role in making a decision as to whether chest imaging should be used in further evaluating these patients. For our paper, we decided to break our imaging recommendations into a few categories. First, we divided pediatric patients who are currently presenting with acute symptoms into 3 categories: pediatric patients with mild clinical features of COVID-19, and pediatric patients with moderate to severe clinical features who are not in a resource-constrained environment. Finally, moderate to severe clinical features in a pediatric patient in a resource-constrained environment. This would include environments where you have limited hospital beds, limited ventilators, and limited staff to take care of the patients. Additional recommendations were also made for sequential imaging studies over the course of the patient's treatment and post-recovery follow-up imaging. For pediatric patients with mild clinical symptoms, the first step is to assess the positive or negative status of COVID-19. This can be determined with real-time PCR where available, or the patients can be classified as presumed positive or presumed negative based on exposure history and local disease prevalence. For the negative COVID status group, no additional imaging is indicated in patients with mild symptoms unless the patient subsequently demonstrates clinical deterioration. In the positive group, patients who have no underlying risk factors for progression or comorbid medical conditions also don't require any imaging deterioration. However, in the COVID positive group, with patients who have underlying comorbid medical conditions that place them at risk for progression, a 2-view chest radiograph should be considered. In a resource non-constrained environment, pediatric patients presenting with moderate clinical symptoms such as significant dyspnea, hypoxia, chest pain, or altered mental status, or other symptoms suggesting impending decline, the first step is to evaluate COVID-19 positive versus negative status. However, regardless of the status, the next step is going to be to consider a 2-view chest radiograph because the patient has significant clinical symptoms. In the COVID positive group, patients who have already undergone a chest radiograph and demonstrate clinical worsening may merit undergoing further evaluation with chest CT. In the COVID negative group, patients who have chest x-rays that are nonspecific, an alternative diagnosis should be considered. However, in the COVID negative group, if a patient has imaging findings which are typical or concerning for COVID-19, a repeat PCR test should be considered to potentially diagnose COVID-19. The final group of decision making for pediatric patients is the resource-constrained environment with pediatric patients who have moderate to severe clinical symptoms. This classification should only be used in settings where laboratory testing isn't available or will take too long to result in order to make triage decisions. Further, it should only be applied in environments where there's a high prevalence of COVID-19 and a patient can be presumed positive based on exposure or local disease prevalence. In the moderate resource-constrained group, the first step is to consider either a chest X-ray or consider a low-dose chest CT. This is going to depend a lot on local practice patterns, imaging equipment that's available, and other clinical decision-making. In patients who have imaging findings, either CT or chest X-ray, which are suggestive of COVID-19, the patients should be triaged as if they have COVID-19 positive status. For those who have imaging findings that are nonspecific, hospitals then will have to make a triage decision based on the level of concern for COVID-19 for the overall clinical picture, the local disease prevalence, and the known resource limitations of that institution. In the final portion of our discussion, we'll talk about sequential imaging and post-recovery follow-up imaging for pediatric patients with COVID-19. Sequential chest radiographs should be ordered on an as-needed basis based on clinical symptoms. This can be used to assess response to therapy, to evaluate patients who demonstrate clinical deterioration, or to assess positioning of life support devices. However, daily chest radiographs have not been shown to improve length of stay or mortality in pediatric ICU patients and thus should not be done. Post-recovery chest imaging in pediatric patients with COVID-19 is somewhat difficult given the lack of longitudinal data. However, we made recommendations based on previous evidence shown in pediatric MERS and SARS. For patients who are asymptomatic and had mild COVID-19 disease, no post-recovery follow-up imaging is indicated. However, follow-up imaging can be considered for asymptomatic pediatric patients who had an initial moderate to severe course, depending on level of clinical concern for long-term injury. Additionally, follow-up imaging may be appropriate in pediatric patients with prior COVID-19 infection who have persistent or worsening clinical symptoms, regardless of the initial disease severity, in order to assess for post-infectious lung injury. In conclusion, the coronavirus 2019 pandemic is a situation. Knowledge about the presentation and evolution of COVID-19 pneumonia in pediatric patients is going to continue to grow as more cases present. The information and recommendations provided by this document may undergo additional refinements moving forward as we learn more about the patterns of the disease in pediatric patients. Practice patterns may vary across institutions, and best results overall will be achieved through candid discussions between individual radiology groups and their respective referring providers.
Thank you very much for listening to our educational video on pediatric COVID-19. And my name is Dr. Edward Lee from Boston Children's Hospital and Harvard Medical School.
And I'm Dr. Alexandra Foust, also from Boston Children's Hospital and Harvard Medical School.